this is an image of a set of twin girls. And like many twins, they were born too early. So in this case, these twins were born 2 months before the planned time. And of course, that leads to a number of problems. Some of the most common problems that you encounter is delayed lung maturation. So the lungs are not ready to meet the world, the outside world, and the challenges there. So there was a lot of discussion about what to do about this. And one of the suggestions was to give the mother corticosteroids when you thought that a premature birth was imminent. But there was a lot of discussion, and a lot of trials were done. And that was actually the basis for some of the first systematic Cochrane reviews that became really groundbreaking. And that systematic review of this intervention is actually the meta-analysis that's depicted in our logo. So for those of you who are new here, don't know meta-analyses, this is what's called a forest plot. The vertical line indicates no effect. The horizontal lines indicates results of individual randomized trials, and they're 95% confidence intervals. So when these overlap the line of no effect, we say the result is not statistically significant. The diamond at the bottom indicates the summary estimate, and in this case, there is a beneficial effect. And it's a very important beneficial effect, because what these lines illustrate is not just numbers. What is counted in these experiments is dead children, arguably the most important outcome in medicine. So of course, this systematic review became very influential because it saves the lives of small children. And many people have benefited from this analysis, including me, because you see, the children you saw in the first picture are in fact my children. So this is what they look like today. And despite their parents, they've turned out very normal. So this is really the classic example of what science can be used for. We do science to improve treatment and benefit our patients. But there is another reason that we do science, and that's to tell us what not to do. And I think my main point today is to tell you that that type of research is just as important. So when my wife and I were in this situation with imminent premature birth, of course the doctors wanted to do something. So one of the things they suggested to do was to stitch up the cervix of the uterus with a piece of nylon string. And it's fairly easy to imagine how that might work. You know, you keep the children inside the womb. But it's also quite easy to imagine, you know, there might be some harms from doing that. It's a surgical procedure, so there's a risk of infection, for instance. So, of course, I looked in the Cochrane library. And there is a Cochrane review that tells us something about the value of that intervention, fortunately. And it's summarized here. So you can see there is 6 randomized trials, a little bit more than 2,000 women. And what they found was that there was no overall reduction in pregnancy loss or preterm delivery rates, so no benefit. But there was increased fever in the women who received this. Fortunately, no serious morbidity, but there were increased use of therapy and hospital admissions. So this is an example of an intervention where the evidence tells us it does more harm than good. So I brought this to the treating doctors, and we agreed that this was probably not a good idea. So my wife did not get this intervention. So what do you do then? Because you have to do something as a doctor, right? You have to help your patients. So what they suggested was strict bed rest. And strict bed rest, you have to stay in bed 24/7. You're not allowed to go to the bathroom. You're not allowed to go get something to eat, something to drink. And it can go on for days, weeks, even months. So that was their suggestion. So fortunately for me, there was a Cochrane review on that. And indeed, it was even in multiple pregnancies. So this was just perfect. If we look at the results, there's 5 trials, 500 women, a little bit more than 1,000 babies, so some must have been triplets. Much the same story, no benefit. But in this case, we couldn't really know anything about harms because it was not reported. And that's a really common problem that we encounter as systematic reviewers. In many trials, the focus is on the benefit. When we calculate how many people go into a trial, we focus on the benefit. It's calculated based on the benefit. Harms can be sort of an afterthought, but the harms are just as important as the benefits. We shouldn't introduce new interventions just because they're beneficial. We always need to weigh the benefits against the harms. So I presented this to the treating doctors, but they were not as receptive. And my wife actually ended up having this intervention. You can imagine how it might work. You take the pressure off the bottom of the uterus, but you can also imagine there is harms. Women who are pregnant are already at increased risk of developing blood clots, and lying in bed is not beneficial for that. It also makes you weaker, which is probably not good when you're giving birth. And then I can tell you there are some psychological consequences of lying in bed for such a long time. So by now, you can imagine, I was generally regarded in the medical department as the relative from hell. But fortunately, we made friends, and we actually ended up doing a Cochrane review together, because that's how most Cochrane reviews are done. Collaboration between clinicians who know what the problems are, and people like me who know something about methods, who can help them do reviews that are hopefully clinically relevant and can help people in the future. But the real question here is, of course, why was it up to me to find this information about interventions that didn't work? Why isn't this really a systems effort? Why isn't there a central unity telling doctors not to do things that doesn't work? It's wasting resources in our healthcare system. And it seems that the hardest thing for a doctor is not to do something. So I think we lack an awareness of the value of not doing anything. There's just too little system effort to de-implement interventions of low or negative net value. So we need to do things differently. Evidence implementation is straightforward. Everybody is enthusiastic about doing new things that benefits patients. But unfortunately, not all new interventions are based on solid evidence, particularly non-pharmacological interventions. So things like surgery, physiotherapy, psychotherapy, although they can be harmful too. I mean, it's not like it's risk-free to go into surgery, but we have much lower standards for evidence when it comes to non-pharmacological interventions. That's a problem. And it's a problem that if we have unclear or too low or absent requirements for evidence, this leads to suboptimal prioritization and implementations of inefficient and harmful interventions, as well as variation in standards between regions. And that's a real problem. So the purpose of evidence-based de-implementation is that we get rid of things that don't work, things that do more harm than good, things that don't benefit anyone. And it's important to realize here that this is not a cost-cutting exercise. This is not about taking things away from people. This is about making sure that we use the resources we have in the best possible way. Doing less of something that doesn't work enables us to do more things that do work. So the challenges really is, well, some of the challenges are that it's very difficult to prove that an effect doesn't exist. I think it was Bertrand Russell who famously said, I believe there is a Chinese tea set circulating around the world, and now you have to prove me wrong. Of course, that's impossible. So we're dealing with likelihoods here, but we can say that in many cases, the evidence strongly suggests that what we're doing is not that helpful. So we cannot exclude that interventions work for individual patients. And this means that there can be a conflict between clinical experience and what the evidence says. And that can be a real challenge as well. Another challenge, and I think we probably met that yesterday, I was talking about breast cancer screening and how Stephen and I have questioned the value of expanding breast cancer screening to women in their 40s in a recent paper in the New England Journal. Is that if clinicians have been doing something for many years to help their patients, and someone comes and tells them what you've been doing might be doing more harm than good, that's a really hard sell. it's a particularly hard sell if you don't have something to put in its place, if you just have to do nothing. If there's a better alternative, you have a much easier way forward. And the last challenge we have is, of course, that there is just a general lack of evidence of many of the things that we do in clinical practice. And that doesn't mean that everything we do is without value or without benefit. So we can't just say, if there's no evidence, we should stop doing things. We have to have some evidence to stop things. But even when we have that evidence, that's not always enough. And I'm going to give you an example. So about 10 years ago, we did a Cochrane review on the value of regular health checks. So something that intuitively makes a lot of sense. And this review got a lot of attention. And I realize, of course, that you're all looking at this wonderful, spontaneous family photo. But it's the headline that you need to look at. One of the reasons that it got so much attention was that this had just been introduced in the UK. And if we look a little bit at the evidence, and it's shown here in what's called a summary of findings table, where you can see the effects illustrated both as relative risks, as absolute numbers. You can see the certainty of the evidence, which is high. You can see how many trials were done, how many people were in those trials. And in this case, for instance, for cardiovascular mortality, we have 9 trials, 9 randomized trials, 170,000 women. If we look at total mortality, we have 11 trials, almost a quarter of a million people in these trials. And we find no effect. The relative risks here indicate that this has no benefit. But like all interventions, of course, it has harms. So should we do this? Well, of course, we can't prove that it doesn't work for some individuals, but it doesn't seem overall, from a societal perspective, that this is a good idea. But the reactions were really different. So in the UK, a Department of Health representative, who for some reason chose to be anonymous, said that, we don't care what the evidence says. We base our program on expert guidance. Whereas in my country, our government at the time had put forward a proposal to introduce this, but they said, okay, we looked at the evidence, we're going to take away that proposal. So it's much easier to follow the evidence for interventions you've not already implemented. It gives you a bias, I would say. So we were unsuccessful in killing off the UK National Health Check program, but sadly, now the dog is dead. So. There is no, there's really room for considering the correlation between healthcare spending and what we get for our money. So here we have the total expenditure on healthcare as a percentage of the gross domestic product, and you can see Italy and Norway is down here. Denmark spends quite a bit more. And then, of course, the US is just off the charts. But if we look at life expectancy, we can see that the picture is completely reversed. The US is down here, and we have Norway up here, and we have Italy and Denmark somewhere around there. So more spending on healthcare does not necessarily lead to better health, and it's because there is many other factors that determine our health, mainly things like social inequality. So some people are clearly getting too much healthcare, and I'm not the only one who think this. So this has been the focus of campaigns from all the major medical journals. We've done a collection of Cochrane reviews of low or no value medical interventions. So another issue that I just want to touch on is the problem that we tend to think in silos. So we tend to look at each medical specialty and each intervention in isolation. And if we do guidelines or we assess the value of an intervention, we tend to look at it separately from everything else. And if it seems that the benefits of the interventions are greater than the harms, then we should introduce it. Then that intervention is recommended. But you then fail to see that what you spend on that intervention has consequences in other areas. And then there's things you can't afford, things that you don't have staffing for. And guidelines currently do not consider the societal perspective or even just the perspective of the entire medical field. That is a real problem. This leads to issues like recommending too many things. So we looked at recommendations from NICE, a very respected guideline organization in the UK, and there are recommendations of what's called individual lifestyle interventions. So when the doctor talks to patients about their lifestyle. And we found that this was recommended in more than 360 instances. 360 instances recommending individual lifestyle interventions. In the vast majority of these cases, this was not based on evidence. And in many cases, the recommendation was against the evidence. The evidence clearly indicated that this did not work. So, of course, if doctors have to follow all these recommendations, they don't have time to take care of the issues that the patients actually present with. So we have real issues with making sure that we spend things optimally and don't just recommend interventions because we think it might be a good idea. It sounds nice. So what we need is really, we should have an centrally organized system where we assess these things based on the principles of evidence-based medicine. Each of these assessments should have a strong independent chair. It's not something that should be decided by specialist societies. These are people with vested interests. These evaluations should also include people who knows about methods. These panels should have the means to allocate, they should have means to allocate to relevant clinical research projects to fill the gaps in our knowledge, because we cannot prioritize rationally if we don't know the facts. So we also need that requirements for how to regulate pharmacological, non-pharmacological interventions should approach each other. And there are really two economies to consider. There is the money, and then there is the time available to clinicians, something Minna Johansson has promoted as something called time needed to treat, or TNT, and there's a couple of references to papers she's published about that. We need to regulate doctors' behavior through financial incentives, and evidence-based clinical guidelines and clinical research should be preferably free of vested interests. And they are really the key to optimizing how we prioritize. And like I said, they need to assume the perspective of the entire healthcare system, not just focus on individual interventions. So I want to finish with a quote of one of my heroes. It's a quite famous quote. It's from Douglas Altman, who's one of the kindest people I've ever met. And he said that we need less research, better research, and research done for the right reasons. That's still true today. It might even be have been more true during the pandemic than any other point in time. But I'd like to rephrase that just a slight bit and say that we need less healthcare, but we need better healthcare, and we need healthcare that's provided for the right reasons.